And I'd like to welcome all to our presentation this afternoon by Dr. Ismail. It's a matter of heart. My name is Maggie Latanzio, and I have the pleasure of introducing Dr. Ismail. I work with her closely. I'm the advanced practice nurse with the cardiovascular division at UPMC Passavant. So I have had the pleasure of working with Dr. Ismail for a few years now. If I could please ask you in the audience if you would turn off your cell phones and your pagers. This is out of respect to our speaker, but also to yourself. This is your time to sit back, take this hour for yourself, and don't listen to that phone. So turn your pagers off, please. Nurses in the audience, for your CEUs, there is a table outside of the double doors here, and there are a couple of our staff members there who will be distributing CEUs at the end of the presentation. And I do have to say that we need to make this formal announcement. Dr. Ismail does not have any financial relationship which exists per the disclosure, and this is so we can distribute the CEUs from PSNA. So let me just tell you a little bit about Dr. Ismail. She is actually a cardiologist. She is a graduate from the Dublin School, the Royal College of Surgeons in Ireland. She has done her fellowship in internal medicine and cardiology at Allegheny General. She has done extensive research, some fascinating research actually in the Pittsburgh area, but also down at Duke University and in Virginia. She is very interested. She has a sincere interest in women's heart health, and I know that she is going to touch base on, some of the things and some of the questions that we all live with every day. So we are going to have, thankfully, a question and answer period at the end of the presentation. And besides that, she's just a really fun person. So if you have any questions about, she's a great cook, loves to drink some wonderful red wines, and she swims, and we'd like to touch base on those fun things too. So I'd like to take this time to introduce my friend and colleague, Dr. Ismail.
Thank you, Maggie. Thank you. Thank you, and as Maggie said, this is obviously a subject that is very near and dear to my heart for obvious reasons. I do treat male patients too, but this has really grabbed my interest over the last few years because we now know more about how heart disease presents in women. I'd like to thank Passavant for asking me to be here, and I'd like to thank you all for being here this late in the day. I know you're all very busy with work, home, etc. In the interest of time, I'd like to go through the lecture if possible, and then, as Maggie said, there's a Q&A session at the end, and I'll answer any question that you like. And there's no question that's silly, so please feel free to ask anything at all. Unfortunately, building awareness of the prevalence and educating people in general and women in particular about heart disease really is paramount in this day and age. There are more deaths from cardiovascular disease in women than there are in men, and hopefully my talk will help explain why that sad fact is. We don't want anybody to die from heart disease, but we certainly don't want women to become the predominant fatalities. Heart disease is the leading cause of death in the United States, if not in the world. We certainly have the better statistics that show us that. It costs a lot of money, and so in this day and age where we're broke all around, it's certainly not something helpful for our healthcare. That 290 billion number that you see here, this slide is about 4 years old, so you can add quite a big chunk onto that. And it probably represents, through different elements of heart disease, heart failure being the predominant one, the highest number of readmissions to hospitals. So patients come in, go home, come back again, come in, go home. And that's just the nature of the disease, unfortunately. Now, this is a very interesting slide because, as you can see, that cardiovascular disease, CVD, has more deaths than cancer, chronic respiratory disease, so asthma, emphysema, etc., and really has, if you add all of these up, they just barely make the incidence of heart disease. Basically, 1 in every 3 adults in the United States will die of heart disease. That's men and women. So that's quite a high percentage and quite a high relevance to us all. Also, this is a slide that makes me very jealous of my oncology friends because they have worked very diligently and very hard at making us women in particular, and also men with respect to their cancers, very aware of cancer and very aware of getting screenings for cancer. You know, we all go get our pap smears, we all go get our mammograms and so on. But how many of us in this audience actually goes and asks or demands to get their heart health screened? Very few. And that's because we're still a little bit behind the oncologists as far as education. And yet, 1 in 8 women in the United States, 8 or 9, depending which study you believe, 1 in 8 or 9 women in the United States will die of breast cancer, but 1 in 3 will die of heart-related issues. So we're really quite behind. As I say, that's when I'm quite jealous of my oncology friends, but I learn from them, and that's why I like to talk about it. I like to educate the community and my colleagues about it, because that's where it starts. We educate in this auditorium, and you take it home, and you take it to your communities and to your relatives, and that's how it propagates. Unfortunately, it's a disease that does not respect age, demonstrated here on this axis. It does not respect ethnic backgrounds either. Traditionally, up till now, we've said that the African American community is probably hit hardest in the United States, but actually the Hispanic community is catching up. We don't have studies yet that reflect Oriental and Asian communities, but they're catching up. And of course, the Caucasian community is also still very relevant. So really, whomever you pick in this country, at whatever age, they have a certain risk of heart disease. I'd like to explain the slide to you, and it actually shows a very alarming trend, as I put here in red. The black shows, the black line shows actually the incidence of heart disease in men. Red shows the incidence of heart disease in women. And this slide goes back to the late 70s. And for those of you who were adults in the late 70s, that was the time that they perfected coronary artery bypass surgery, which I don't know if you know, but coronary artery bypass surgery, otherwise known as CABG, preceded angioplasty and stents and so on. So basically, a lot of men were getting CABG done because they had heart disease. And men became more and more aware of coronary artery disease and high blood pressure and high cholesterol and so on. And if you went to the beach, almost every 4th man had a bypass surgery graft down their chest. And that continued to decline, though, because men became more aware as they started knowing about bypass surgery, seeing cardiologists, seeing their internists more. They got to learn about diabetes, high blood pressure, etc. So the incidence of heart disease actually started to fall. In women, it started to escalate. 2 reasons. One is women started going to the ER when they had their discomfort. And also women, unfortunately, started to smoke more because of modeling, staying thin, etc., etc. And we still had not identified then that heart disease does present differently in women. We still had not kind of been chasing women as vehemently as we chased men as far as lowering their risk factors. So they crossed. Those lines crossed somewhere in the mid-80s, and as you can see, unfortunately, in women, it continues to rise. And if I were to continue, this slide ends with the millennium, but if you were to continue, you can see that this line continues to go up, this line continues to go down. I don't want men to go back up again, but I certainly don't want women to stay up there. We need to catch up and come down. There are gender differences, and unfortunately, because of the gender differences, a lot of the times women either don't identify their symptoms enough to cause them to go to the ER or to a physician, or when they get there, because their symptoms are not so typical, then they are not treated necessarily in the same way. So, for example, a lot of far fewer female patients were actually admitted. Far fewer female patients were identified as having heart disease and treated as such. Far fewer patients were identified as having an active, even a heart attack, and given a heart catheterization or whatever treatment that would otherwise be appropriate at that time. Not because the ER physician had it in for them, it's because neither the physician nor the patient at that time, and to this day even to a certain degree, don't recognize those symptoms as being heralding a major cardiac event. So Why is that? Because I can tell you from all the women I see, very few of them tell me that they have chest pain. They'll describe it every which way, but not chest pain. They'll say dull, ache, even shortness of breath, just not feeling well, just not able to do all the chores that I normally do, doc. So, I mean, for me to wait for them to say that I have chest pain, and better still, chest pain going down my left arm, a lot of women would have not done well in my practice. So that's the first thing that we have to educate ourselves, and that we have to educate, of course, the physicians, the nurses, the ER staff, is that not every woman is going to come clutching her chest and giving the classical textbook symptoms and saying, please admit me because I'm having a heart attack. So, and actually, a lot of women, more women I think, have described dizziness or shortness of breath or even just anxiety or even a feeling of impending doom. But if you ask them every which way, did you have chest pain? No. Chest pain never comes into it. So we need to stop, you know, waiting for the chest pain to happen. Now, having said that, I don't want you guys to leave here and be anxious every time you have some kind of a discomfort that you're going to run to the ER or what have you. I want you to live your life as normally as possible too, and get on with exercise and everything else I'm going to ask you to do. But at the same time, if you have risk factors or if you have had a problem, you know, then you may not have a typical presentation such as a male patient may. A lot of women also, we tend to be very bad about putting ourselves as number one. Especially I see that in my friends who have families, and in particular who have children. They will go home and they'll finish the laundry before they come back and get admitted. I've had a couple of patients say that to me. I'm like, I'm going to admit you now from the office. Well, can I go home? I left the laundry. I just need to put it in the dryer and I'll be back. I mean, honestly, this is no joke. I mean, and it's not, she's not being disrespectful to me. She's not, you know, being stupid. She really, that is the priority. Let's make sure that gets done, and then I'll take care of myself. And we're all guilty of it at a certain level. I may not do it with health issues because I'm maybe more aware, but I'm sure I do it in other aspects of my life. So that's something that I don't know how we can learn this. Maybe it's genetic, maybe it's not, but we have to try and definitely take care of ourselves. And I think one of the ways to do that is to actually get yourself screened and get yourself looked at and identify your cardiovascular risks. And that way you know, you're in the know. You're not going to guess and get alarmed every time you have a symptom that wasn't there a day before or a week before. This is a bit of a technical slide, but I want to show you some of the usual offenders that we all have come across, whether you've heard it from your relatives or you yourselves have experienced them, or we hear it in the office every day. The endothelial dysfunction, the endothelium is actually the lining of blood vessels. Any blood vessel in our body is lined by something called the endothelium. And that's actually, it's not just like a layer of skin, it actually produces hormones and enzymes that regulate the tone of the vessel, whether the vessel gets bigger, whether it goes into spasm, depending on the blood pressure, depending on the blood flow. So it's a very, very intricate chemical balance. And things that destroy the endothelium will therefore destroy that balance and can start causing the problems and the risk factors that are associated with not just heart disease, but cardiovascular disease in general. So we'll just, for the moment, ignore our male compadres, because in women, the magical age is 50 or greater than 50. Well, that's true unless you've become menopausal at a younger age, which some women do. And I can tell you, with all the advances in oncology and cancer treatments, we can see a lot of women now becoming menopausal in their late 20s or 30s, depending on the type of chemotherapy that they received or radiation therapy, or if they had ovarian cancer and they took the ovaries out, then they're menopausal that day. So and another myth I want to burst right now is you're not menopausal when they remove your uterus, or when you stop having menses. Periods. You're menopausal whenever your ovaries fail. It's not the uterus, it's the ovaries. So if somebody had a hysterectomy 20 years, 25 years ago, but they left the ovaries in, that's fine. That woman didn't have her menopause that day. She probably, if you ask, 20 years later, let's say she had her hysterectomy at the age of 25 or 30, probably 15 years later, she started having hot flashes. And she did because that's when she was going through menopause. Also, as I mentioned, menopause is not equivalent to having you stop your periods. There are actually about 2 to 3 years before you completely stop your period, which we call perimenopause. And that's when you might have, irregular menses. Some are light, some are heavy. You get 3 in 1 month, you get none for 6 months, and they're back again, and so on and so forth. As far as the heart is concerned, that is menopause. So all the things that are going to change and cause your cardiovascular risk to go up are happening already. So you don't have a free pass until you stop menstruating. So I just wanted you to be aware of that. And some of the things that affect us because of menopause is because of all of these things that start to happen. For example, high blood pressure. This is a technical term for high blood pressure. Women who were not hypertensive or were controlled with medications, once they become menopausal, their blood pressure can come out of control again. So don't be surprised if that happens. It's not because you're not responding to the medicines, as your system is changing. You also can have pre or diabetes ensue once you become menopausal. And if not, if you have hyperglycemia, which is high blood sugar, so you're pre-diabetic or diabetic before menopause, that's a very, very big risk factor. As a matter of fact, menopause and diabetes individually triple your cardiovascular risk as women. So that's very important to recognize. We talked about menopause here. Of course, tobacco abuse. Tobacco, we've known from studies, the minute somebody inhales from a cigarette, within 20 seconds, that nicotine hits that endothelium and causes spasm. So imagine what happens when you're a chain smoker. If you chew tobacco, I haven't seen many ladies who chew tobacco, but if you chew tobacco, that gets into the system even faster, and it's a much higher concentration. Cigars, I won't go there, but I don't know. It's the same thing. I mean, you don't inhale cigar smoke, but still it dissolves in your saliva, so it does affect you. Physical inactivity goes without saying. Low HDL. HDL is the healthy cholesterol, and that unfortunately will start to fall, which always remember, HDL, H is for healthy, and we need the level to be high. But that starts to fall in the perimenopausal period of time. Simultaneously, LDL, L for lousy cholesterol, we want it low. That's going to start to rise also around the perimenopausal area. But even without menopause, if you have this abnormality or a high cholesterol, high LDL, then you're also affecting the endothelium. So that's all well and good, but what actually happens in the body? This is a blood vessel, brand new blood vessel. You're just born, or you're just a very healthy person, and this area here is the endothelium, this little dotty thing. This is muscle, and this is covering around the blood vessel. As we go around and do a little bit damage, you can see that the endothelium, the dots get fewer and far between because it's not as healthy as it was. Do more damage, and that's going to continue to happen. But notice also that the blood vessel has started to thicken. Now, all blood vessels in the body, their main object, especially arteries, is to get blood supply, carrying oxygen to a certain organ. So the blood vessel will do everything it can to actually maintain that opening or the lumen of the vessel. So therefore, as we continue to put stuff in here, this yellow is what's called a fatty streak. And what that comes from is when you have too much cholesterol or you've done damage to that lining, then the white cell counts in the blood, which normally we use to fight infection, pneumonia, what have you, but they are also repair cells. So what they do is they try and contain that damaging cholesterol, and they form what's called a fatty streak because it looks like a fatty streak. The bad thing is once you have a fatty streak, it's yours for life. No matter what cholesterol medicine I put you on, I may normalize your blood level, but this fatty streak is yours for life. And they have discovered it in autopsies on children as young as 2 years of age. So there's no magic number as far as age as to when this happens. Now, if you continue, though, not to take control of your lifestyle, etc., you're going to have a lot more cholesterol forming, and that's what we all know as the plaque. So once the plaque happens, again, that plaque is yours to stay, and with the drugs we have now, not many of them, far from it, have any effect on actually reducing this plaque. So again, that's why I say to patients, don't wait, treat it now, because what you have right now is yours to stay. I can hopefully try and prevent further plaque from developing as fast if I control your cholesterol. So if you have that, if you've had, you know, that discussion with your physician and you say, give me 6 months, I'm going to do everything I can, what have you, yeah, but, you know, that's going to get worse. And what's there is yours to stay. Now, notice also what I told you before is that as the vessel is trying to keep that opening the same size as before, the vessel has to stretch. Once you stretch an artery, it's no longer pliable. And that's where the term you've heard hardening of the arteries comes from. And that blood vessel is no longer really what it should be. And that's when people start getting problems, for example, with their blood pressure, and the blood pressure goes up because the vessels are no longer elastic. Now, if worse comes to worse and you actually continue to do the bad things, then this is going to happen. At the very sides of the plaque, where it's the weakest link, so to speak, you're going to get a rupture, and that fat will pour into your bloodstream and start a really bad reaction. And that's when a thrombus or a blood clot happens. And depending where the blood vessel is, you're going to have a heart attack if it's in your heart, you're going to have a stroke if it's in your brain. So, and that happens differently in men versus women. In women, it tends to erode very slowly, and that's why women don't really get those typical symptoms all the time. In men, it just ruptures like a volcano, hence clutching the chest, etc., etc. So that was one of the first things that were identified, and they feel that it has to do with estrogen. But that was one of the first things they identified that actually happens in our bodies that makes our presentation different from that of a man having a heart attack. And then, as I mentioned, once you have the volcano erupt, then you're full of clot in that blood vessel, and you can see the opening is even smaller, and that's when the event occurs. This is what it looks like, basically another view. Here's a nice brand new clean vessel. You keep adding, so to speak, crud to it, and that's what it looks like. And depending where it's at, if it's in the heart, as I mentioned, heart attack, in the brain, a stroke, and of course in the legs or in the arms, then you can have a similar problem. And that's when you see sometimes patients end up getting amputations for their legs and so on, because this has happened in their leg vessels and it was not able to be reversed. Okay, now that's all and good, for what happens at the cellular level and what have you. But when it comes to, as I say, educating women, if I flash this slide, all the time, someone will just, men and women can get bored and say, yeah, whatever, that doesn't apply to me. We always think it's not going to apply to me. That other person will get it first because. Well, not necessarily. A study actually a poll was done here in the United States, and the findings were very similar across the country to what we have here in Western Pennsylvania. And basically, when they asked the women if they think that they have cardiovascular risk, about a quarter of the women that were asked said, yes, we do. We think we have cardiovascular risk because A, B, C, whatever. However, when they really looked at them, the majority of them, that red part of the pie, the majority of them had cardiovascular risk. So the difference between the women who knew it and thought it, and the difference between the total are women who were oblivious about it. Again, not because they're stupid, it's because they really did not know that these are the risk factors that they should have looked at and looked into. About 3/4 of the women that were given the survey said that they would like to get the information from their physician about cardiovascular disease. And remember, the younger the woman, the physician could be a PCP or more likely just the OBGYN. A lot of women don't see even their PCP, but they see their OBGYN on a regular basis for the reasons I explained to you. And they don't see a cardiologist or what have you till way later in life or after an event has occurred. So 3/4 of the women said that they would like to get the information. In reality, only about a quarter actually made the effort. And the effort should be two ways. I mean, it should be us as well as the patient saying, I want to know. But I think it should start with the patient too. About 2/3 of the women said that, getting a mammogram every year is important, and just as important, they'd like to get screened and checked for heart disease. That's very good. That would make my life so much easier. but actually only about 12% of the women actually followed through with that. They still did their mammograms, but they didn't really look at the heart. Again, the education is not there yet, and that's what we have to work on. About half the women said that breast cancer is what's going to get them. But as I mentioned to you, in reality, it's really not going to be that at all. It's going to be heart disease. So that's kind of where we are, and that's where the education has to start. As I mentioned to you, I've already talked about this. You guys have been out in the exhibit. You know about BMI. You know about diabetes. Microalbuminuria is where we secrete a certain type of protein in the urine, and that can herald the problem with heart disease. That is checked automatically if you have diabetes, but now more and more physicians are checking it because it can actually, as I mentioned to you, herald heart disease. The age, as I mentioned to you, that's kind of not really, I don't believe this part of the slide because it has to do with when menopause occurs. And family history is very important. The younger the person in your family had the heart disease, the higher the risk it is for you. And the sooner you should get yourself checked out for heart disease. To all of this, I also add sleep apnea. More and more we are discovering patients have sleep apnea, and the most common presentation is fatigue. Doc, I slept all night, I woke up and I felt very, fatigued. We all have very difficult and sometimes complex lifestyles, but anytime somebody tells me that, I always check for sleep apnea. And I'm sorry to say that half of the time I'm right, they have sleep apnea. They don't have to be short, they don't have to be obese, they don't have to be old, they don't have to snore. And that's the biggest thing is people, I don't snore. That's fine, that's great, that's better for your spouse's ears, but we're still getting checked. And you have to have a sleep study. There's no other way to diagnose it other than a sleep study. And if you have sleep apnea, you have to treat it with the machine, because otherwise, it's just a diagnosis and you're not doing anything about it. So that's another big factor that's important, because if sleep apnea is not treated, it can certainly precipitate heart disease. It can precipitate high blood pressure and make high blood pressure very difficult to control. It can make diabetes very difficult to control. And basically, none of it is good for you. So let's go to the doc, and what are we going to say to the doc? Well, first, again, the awareness and education, and hopefully if I've been able to impart some points to you. When you go to the doctor, please ask the doctor, I want to know what my heart risk is, or I have this presentation, or I have this family history, and I want to know what it means to me. So it is two-way, and don't be dissuaded. If they say no, I want to. And it's your right to want to find out. The examination, of course, is carried out by the physician or the nurse practitioner or the physician's assistant in the office. And one of the things that we look at, of course, is blood pressure. And this is an ideal